Thank you for joining us today. We have just a few housekeeping details to share before we get started. This program is being recorded today, and the link for the video will be available within a few days. Recording will be shared via email and will be posted on our website, and continuing education credits will be available. When today's webinar concludes, participants can click on the evaluation link in the description below this video window to obtain continuing education credits. So welcome everyone. I am pleased to present to you all a webinar focused on the impact of COVID-19 on palliative care. My name is Nelia Jane. I am the inpatient consult service director for the adult palliative care service at the Dana-Farber Cancer Institute and Brigham and Women's Hospital. And I have the pleasure of having four of my colleagues join us to facilitate a panel to speak us to our experiences about caring for patients during the time of COVID. So I'm going to start with introductions of who you'll be hearing from. To start, we have Rochelle Bernacki. She is one of our adult palliative care physicians, and she was spearheading our efforts in collaborating with our general medicine colleagues and the emergency department colleagues to care for patients affected by COVID. She was joined in those efforts by Kate Shaka, who's one of our nurse practitioners. She typically is the lead nurse practitioner on the Kidney PAL service and was redeployed to the general consult service. And her colleague, Kelsey Colleen, who is the Kidney PAL social worker, was also similarly redeployed throughout the hospital to assist patients with COVID diagnoses. And finally, we have Anna Hoffman. She is one of the medical interpreters that we work very closely with in our palliative care team. And we're honored to have her join us. We often think about her services as an extension of our own. So what we are going to do today for the format is we thought a little bit about our experience and reflected back on how it felt first to be in the hospital or to be removed from the hospital, trying to facilitate the care for these patients. And a little bit about what it felt like to be at the bedside, what we encountered, what were some of the challenges, and then some of the things that we're still thinking about, hoping that all of this together will be useful for those that might be experiencing surges in their own cities currently or have similarly had experiences over the past few months. So to start, I wanted to ask Kelsey and Kate to reflect on what you were most struck by when you first encountered a patient who was COVID positive. And I'll ask Kelsey to start first.
Sure, thanks, Nelia. So I'm the social worker. I was working remotely from home, still am. And one thing that I saw from the beginning, which was very clear, was that I found that there was very little differentiation between patients and family members. It sort of felt like everyone was a patient. Part of that was because I was calling everyone, so each person was a phone call, and whether I was talking to a patient or a family member, the conversations were very similar. It was always about COVID, always about the stress of the pandemic, and because family members were at home and either had COVID themselves or were equally at risk, they required just as much education and emotional support as the patients did. So oftentimes when I was calling families, the conversation quickly diverted from the patient to the family member themselves and their own distress, and that was unique.
Kate, how about for you?
I think it's interesting to think back on. When I think I was the first couple of days when COVID started to surge in the hospital, we were asked to kind of leave the bedside and stay home and do a lot of virtual work, and which I did for a few days. And then I really had this moment where I was like, I can't really do a job that I feel like I want to do so well. I just can't do from my house. So I came into the hospital to see a patient, and I remember walking kind of into the room, and the patient was in respiratory distress, close to the end of their life, and the amount of fear and kind of anguish, and they were kept repositioning themselves, and it was just kind of like walking into this, the room was so tense, and there was so much anxiety and fear of the patient, and they also couldn't breathe, and we were trying to manage the symptoms, and I was behind a gown and a mask and gloves and a shield, and it just felt so like nothing I'd ever really experienced before, and kind of very surreal and just really hard to access skills that I feel that I know, but when I was in that room the first time, like kind of frozen, didn't know how to help or what to say or anything like that. So kind of like without a roadmap.
Thank you so much for sharing. I know, Anna, it was pretty striking for you the first time you stepped into the hospital once we started to really fill up with patients who were COVID positive. Could you speak a little bit about what your first impressions were?
I was 2 days at home and 3 days at the hospital, and it's just like, I was like aware that how quickly, the patients would discompensate, and how quickly, like all of the sudden, they were like they needed to be intubated, and they didn't even realize that. They were like, no, I'm breathing well, and that was I was struck by that. How fast it was changing from like breathing to just really having a difficulty and couldn't catch the breath. So yeah.
And I know one of the things that was really unique about this pandemic was that all of us that typically work in healthcare environments felt just as vulnerable in a lot of ways. And I'm wondering for those that were on site, I'll ask you, Anna, to start, just how did it feel to be going into the hospital, and what was that personal impact, and how did you navigate that?
Well, it was very, very scary because we didn't really know much about the virus. So we didn't really know how it was transmitted, and so it was very scary. Like I didn't know if I was, did precautions enough, like not to bring it home to other friends, to coworkers. So I was very, anxious. I was very anxious at the beginning, definitely, and that was my put on that.
And one of the other things that I think some people don't know is that in efforts for conservation of PPE and because there was so much unknown about the transmission patterns, we also had to ask a lot of people to not come into the hospital, which posed its own challenges. And Kelsey, you mentioned you were one of those clinicians. Could you speak a little bit to what that experience was like, being removed from the hospital setting?
Yeah. It was odd at first. At first, it felt like I was sort of a firefighter asked to help from the fire truck parked down the road. I could kind of hear on the phone the distress and the chaos and the distress of people, but I couldn't see it. And that was hard to kind of fully engage and be able to help and guide people through something that I wasn't fully aware of. I kind of thought seeing it would ease my anxiety somewhat, like the unknown of it was hard, but as time went on, I've come to really appreciate being removed, and in that being protected by the trauma that I know firsthand frontline providers dealt with and are now processing. I feel grateful kind of to have been protected from that.
Thank you for sharing that. The other people that were very obviously missing from the bedside were family members, and that certainly impacted our practice. We heavily rely on patient support systems to help us and help them navigate serious illness. I'm wondering how you all felt you were impacted by the lack of family members in the hospital, or how the patients were impacted. Why don't we start with Rochelle?
So I would say that this was one of the most difficult aspects of practicing during the pandemic. I particularly recall one talking with his son and discussing whether to transfer his mom to the ICU, and him saying, Dr. Bernecki, I understand what you're saying, but I don't see how I could possibly make this decision without seeing my mother in person. And so at the time, our visitor policy was just that if people were actively dying, people could come in. And so I ended up speaking with the charge nurse and the administrative officials at the hospital, and he was able to visit and make that decision together. But I think that without that, it would have been next to impossible to, and I think sort of reiterating what Kate was saying is that some things just can't be done remotely. And so I spent a lot of time going through the administrative kind of hoops to get family members in. We had lots of challenging situations with family members that were COVID positive and their loved ones dying, and really, really difficult situations. But for the most part, I think we were able to get family members in when they needed to be. And as time moved on, we were able to get some necessary kind of exceptions to the visitor policy, which I think were really helpful for patients and their families.
Yeah, and I remember hearing reflections. It was, the hospital's response was really incredible. It was just more that it was an added layer of our assessment and intervention when we were already modifying a lot of things. Kate, what else would you add here? How did it impact to not have family members at the bedside?
I think kind of going off of what Rochelle said, like when that son could come in and make the decision, like that's what he needed. Guiding patients' families who couldn't come for their own health reasons. So I had a patient whose mother was very elderly and they were trying to make a similar decision, but they couldn't come. And I ended up, it was kind of at the start, and there weren't a lot of iPads, and we weren't doing a lot of that kind of a thing. So they were really basing what they were going to do for treatment based on my recommendation. And I think it just added so much weight on what I was telling people was my recommendation. So it's like, when I do that on a daily basis, I can point to the patient and say, look here, this is what's going on. And patients' families see it, they understand it, and they hear me. And when it was just me saying, I don't think we should intubate this person because of X, Y, Z, and then the family just saying, okay, well, I trust you. It just it was so much more weight on my recommendations, which caused me to reasonably, and I think rightly, question my own recommendations more and more and more. But it was definitely hard, and especially being kind of a new clinician and still being green myself, and then trying to have confidence, but also make sure I was doing the right thing at the same time, was something that I really struggled with kind of internally at the start. So and if patients' families are there, it's so much, it can be easier in that way. So that was a big difference, that the change of not having families in kind of made an impact on my practice.
Thank you for sharing. I was also wondering, Kate or Rochelle, I think one of the most heartbreaking aspects of working in this pandemic was knowing that not everyone would survive this illness. And in palliative care, we pay close attention to how people say goodbye and trying to facilitate those goodbyes. I was wondering if either of you might speak to what was different about that when families were restricted from being at the bedside.
So I think that, sometimes people had to do that via iPad and I think that's really, really hard. It's hard for the family member. It's hard for the clinicians. The nurses, it was just really incredibly difficult. It's not the same as sitting next to someone and holding their hand and just being present. So even when people could visit, they were scared too. And so it added on this additional layer. They were scared for their own health. And, even one person said to me, I don't know how you can do it. This is terrifying, And so to have that on top of losing a family member, especially, I think one of the things that's really striking about this is we're not really used to people dying of infectious diseases, at least not, without a prolonged course and that for me was really a different, I've been practicing 20 years and I've, never really seen that. So that was just incredibly challenging. So
I remember just sometimes feeling like part of our goals of care discussions were wrangling with the choice between patients dying alone in a hospital setting or being able to go to a community setting where they might be reunited with family members for a short period of time. And that was really distressing, for a lot of people on our team.
And even we had some patients who survived and were very confused or had delirium and were perhaps persistently positive for COVID and we're between a rock and a hard place, and ended up sending home some patients who had persistent delirium, who were COVID positive, which poses a lot of challenges to the family, risk for the family member. Although it's probably the best thing in terms of that patient improving, like if they're around their familiar environment and with their family, that's their best chance of getting better. At the same time, we really, struggled with those kinds of decisions. And every time we came to a new decision, there wasn't any right answer.
I think like the logistical aspects of actually having people say goodbye, if they wanted to say goodbye, with an iPad in the room with the nurse or not with the nurse, or who uses the PPE to go in to bring the iPad in, and like what would in a normal time be like, oh, I'll just walk into the room with an iPad and help them say goodbye, took like 15 or 20 people to have family members be able to say goodbye to somebody. So it was like a team, it always felt like this big thing that took hours if you wanted to orchestrate like somebody's parent saying goodbye to their child or somebody's spouse. And it would just take it took so much manpower to get those little things done that we would think of as like a daily, like kind of a routine thing.
Yeah, a lot of added layers of interventions that we would never have predicted pre-COVID. I wonder, Kelsey, as somebody that was interfacing with families, almost in a similar position where you were removed from the hospital, I wonder if there's anything else that you wanted to add.
Yeah, not being allowed to be in the hospital was obviously distressing for most that I spoke with. And it was like an ultimate loss of control for these families. A lot of these patients maybe had been sick prior, and these families were maybe caregivers for years and had essentially kept these patients alive for years by being there with them at all times. And so when patients were at the hospital and they weren't allowed to be there, they felt very guilty. And they also felt a little bit like the patients were just going to suddenly decline because they were now not allowed to be there. And I did see that happen in some cases, which was really, really distressing. There was also a guilt element of, as someone mentioned, the patients were often confused and begging family members to come in and not quite being able to understand the policy or why their loved one wasn't there. They just knew they weren't. And so for the family member to have to keep repeating why, and I'm sorry I can't be there, that was really hard for them.
I remember you and others also reflecting on those same devoted caregivers may have been separated for many months even before they came to the hospital because of the increasing visitor restrictions in the community settings like skilled nursing facilities. So it might have been a very long time since someone had been able to unite with their loved one, and then to hear that they were not doing well was even more distressing. So I wanted to think a little bit together and describe what were the most prominent symptoms that people observed. As Rochelle mentioned, we don't typically care for people who are dying of infectious diseases and infectious diseases that are rapidly changing and cause rapid clinical decompensation that often. And so this was a whole host of new symptoms. Kate, could you speak a little bit about what symptoms you most commonly observed and how it was to manage them?
Yes, I think two things come to mind immediately. One was the delirium element. So I think of the patients that we saw, a super, super high percentage of them, probably, 80 or 90% were delirious at some point during our care for them. And I remember running my list one morning and be like, every single one of my patients is delirious. So that was kind of what stood out to me as one of the more prominent. And it waxed and waned as delirium does, and came in kind of all different on the spectrum of delirium, but mostly hyperactive delirium and people getting really agitated and pulling at things and just not being able to settle. And then along with that, and I don't, tied together, I think, was this very labile oxygen requirement and dyspnea. So they folks would be okay in the day on, 6 or 7 liters, and then overnight at 2 o'clock in the morning, they would need 15 liters and a non-rebreather and be really agitated and then kind of settle back out. And that would happen that we would watch the waves of it. So it would happen 4 or 5 nights in a row and then would go away and then would happen again. And I think those two things kind of together made everything really hard to treat. I mean, it was almost impossible to treat this acute dyspnea that we weren't sure, in 20 minutes, it could be fine. So those are the two kind of symptoms that kind of jump right to mind.
And people have talked a lot about the role of proning patients. And of course, in the ICU, when they're sedated, it's there's a proning team often, and patients are not interactive. Did you see anybody proned or being recommended to do that when you were caring for patients on the medical floor? And what was that like in terms of that management without the ventilator?
Yeah, I think we had a couple people with chronic pain issue that were supposed to be prone but couldn't. So that was okay, let's treat their pain so that they can prone, which was a crazy, kind of a crazy thing to do. But in folks that were already established as DNIs and did not want to be intubated at all, it was quite common as their oxygen requirement went up that they would be the team would say, okay, I think we should have them prone. And then they would be prone with 15 liters on or something like that. And it was really hard. I had somebody that was prone for 7 days on that amount of oxygen, just to try to avoid being intubated. So that there was definitely happened. And added to, if you add delirium to the proning and that, it was really difficult, I think, and really hard for nursing too, with bedside nurses who were trying to care for these symptoms and trying to help.
Rochelle, I know that you were often at the patient's bedside as well. I wonder if there's anything else that you wanted to add.
I think the other thing that was really hard is that the proning definitely worked. It was almost miraculous to watch it, like when you flip someone over and watch their saturation go up. But the thing that I was really challenged by is in order to prone them, they had to be able to turn themselves back over. And the challenge was the patients with delirium. And, could a delirious person, I would argue that some patients with delirium can turn themselves back over and others cannot. And so, it sort of depends on the degree of delirium. And it was really hard to make decisions about how long some people could be proned, and it was a challenge because it did work. But you wondered, you could see that their breathing eased and that their oxygenation went up, which seemed like a good thing. But you also worried about them. We're so used to seeing patients lying on their backs and being able to see their face, and to look on an iPad and see someone lying, with their face down was just hard to assess, how are they really doing?
Thank you for that. So the other thing that we have as a group talked a lot about is that there were a lot of unique aspects to providing palliative care during this time. And the pandemic it kind of redefined palliative care in a lot of ways. Maybe we'll start with Kelsey for this one. What were some of the unique aspects of providing palliative care that have been different from your prior clinical experiences?
I think just due to the nature of a pandemic, it felt like there was a collective state of grief and just a heightened sense of urgency in our society and in our community that at times felt like it almost primed people to have goals of care discussions. It takes a lot of work for us to get people to a place where they're able to have hard conversations about end of life and make any decisions. So in some ways it felt like the pandemic did a little bit of that earlier work for us, and that some people were already in that headspace when we met them. It felt a little accelerated in that way.
And Kate, anything to add?
I think that one of the most unique things about this was that we didn't totally, totally know what the best recommendations were for patients. We didn't know, we didn't even a little bit know. So we were seeing preliminary data about what the kind of intubation rates and what the success rates of interventions like that were out of other places in the US and overseas, but we didn't really know how that would translate into our patient population. And it, you know, part of palliative care is finding out what's important to the patient, and then based on that, making a kind of a medical recommendation or working with the team to figure out what care plan makes the most sense. And it was just so hard because we didn't know what the outcomes were going to be. And patients would look at me and say, okay, well, if I do that, like, what's the chances my wife's going to recover or something? And I was just like, I don't know. I mean, we have different statistics, and we talked a lot about this, Rochelle and I, at the start of COVID, and we went back and forth, and it was, should we base our recommendations on this? And you know, all of these different factors that we thought so hard about, but in the end, it did feel, it was uncomfortable, and it brought me kind of crashing back to my palliative care basics, about just getting to know the patients and figuring out what was important to them, and then trying our best to come up with a good path forward that honored that. And also being uncomfortable with the fact that I wasn't sure what the outcomes were going to be and what those numbers would look like.
I think the other thing that was striking is, I love Kelsey, I totally agree. People were ready to engage in conversations, and at the same time, they weren't quite ready to make decisions a lot of times either. And I think that's something that Kate and I struggled a lot with. You know, I think it was useful to ask people ahead of time if they thought about these things beforehand, and if they've already come to decisions, but asking people to make decisions before it was absolutely necessary, or even, you know, I think that was just not really doable. And I think we tried that a little bit in the beginning and realized pretty quickly that it didn't work. And just like Kate said, you know, kind of went back to, let's just get to know this person and figure out what's going on for them. And I think some of that initial like wanting decisions was our own potential anxiety about, you know, how many patients are there. I mean, we saw the numbers going up every day, and I think that played into this, you know, need for definitions and need for, okay, this person might be DNR, DNI, and really trying to suppress that, and in a time of a really a crisis. So I think we pretty quickly went back to our roots, but it took a while, and it took a lot of discussions and a lot of processing amongst ourselves and our team to sort of feel like we were making the right decisions, or helping in the right way. And I think there's still some underlying kind of, I don't know if I want to call it guilt or grief and not knowing whether we actually did. You know, we were really kind of working in we really didn't know anything. And so that made it really difficult to figure out how to help.
And I think too, another part of our job as palliative care clinicians that we think of is being able to give people warning shots about kind of what might happen next, and being able to say, oh, this is what you might expect. And then all of a sudden I was left in a position where it's like, I actually I don't know. I can talk you through, I think I said a million times, is it okay if I talk to you a little bit about what COVID might mean for your, and then I would, and say, this is the spectrum of things that might happen. They might be totally fine, and they might not all of a sudden. So it just felt like I couldn't even say, hey, this is what most likely is coming. So that part of palliative care kind of got stripped away very quickly.
I think those are really excellent points, and I actually just want to highlight them because I think those are such important takeaways. All of us were anxious, and we talk about how when the people that we care for are emotionally heightened, it's hard to do the cognitive processing. And that was one of the workarounds, was to just rely on the foundational skills that we have built and do what it is that we do, get to know people and their loved ones and what's important to them. And I think also letting go of an outcome, similar to the patients and families not wanting to make a decision, we had to get very comfortable not making a strong recommendation. And that was a change in practice for a lot of us who are very used to doing that. when we're able to preview somebody's illness trajectory or prognosticate in a confident way. But as Rochelle mentioned, when we started to get more comfortable doing that, we were able to get more information as well as what are the possible trajectories and at least give knowledge and support. That actually leads really well into the next question that I want to talk about, which is there were things that changed in how we delivered palliative care. One is just the content of our palliative care consultations, as we just were speaking about. And then some of it was through the illness trajectory, what kind of advice and guidance we were giving patients and families, how were we identifying patients that needed us. So why don't we start with that? What were some of the efforts that were done to identify when patients needed a palliative care consult and when we should be interfacing them after a COVID diagnosis? So Rochelle, why don't you start us off there?
Okay, that's great. And then Kate was the amazing kind of scroller of everyone in the hospital. So early on in the pandemic, we realized that it was I'm also a geriatrician, and there were that this disease was primarily affecting older adults. So we kind of quickly worked with an interdisciplinary team to come up with a kind of protocol for the emergency room. And the first thing that we did was decided that everyone over age 70 who came from a nursing home had a diagnosis of dementia or was frail, and we used the frail scale to define that. And that just asked questions like, can you walk up a block? Can you walk a flight of stairs? Are you on more than 5 medications? Those kinds of things. And so we ask our emergency department colleagues to screen in that way, to screen for those things and to call us. And we set up what we call the geriatric COVID pager. And we tried that for a week and we didn't get any calls. So we went back to the drawing board and said, okay, and I have to emphasize the ED was under enormous stress at this time, and it just wasn't feasible for them to do this kind of work and actually make it happen. So what we did instead is I work with a PA who is actually a surgical PA who has additional training in geriatrics, and surgeries were canceled. So our program in geriatric surgery was not happening. So she actually proactively screened the patients in the ED for these things, for nursing home residents, dementia, frailty. And then she actually did something called the clinical frailty scale, which is works from someone who's very fit. So you could be a very fit 90-year-old or a terminally frail 90-year-old. And so she was able to categorize people by talking to their families and looking at their medical records. And for the people who were robust or not frail at all, we gave them usual care. We didn't do anything additional. For people who were mild to moderately frail and they had a clinical frailty score of 4 to 6, those patients were triaged to geriatrics. And things like trying delirium prevention were done, making sure they had healthcare proxy, those kinds of things. And for those people who were more moderate to severely or very frail, we did proactive palliative care consultations. And we just looked at our data. Most of the patients that came in that met the criteria needed palliative care consultation, and sometimes on an urgent basis. So Kate and I went down to the emergency room on a number of occasions to go see those patients and clarify goals of care. We had everything from, patients that, their healthcare proxies were very clear that this patient would really, really only want comfort measures. So we were able to avoid things like additional tests that might be distressing, and also a lot of work, to get done. And then also have really crucial discussions at the moment that they needed it. So if someone was very short of breath and maybe needing intubation, to make sure we had a conversation with them or their loved one about what they really cared about and whether or not what was important to them and what kind of medical care they wanted. So I think it worked for the most part. It was definitely a work in progress and changed over the course of the pandemic. And that was just one of the efforts we did. I also want Kate to talk about her kind of amazing scrolling of all the COVID patients in the hospital.
Yeah, I think that was, the medical director of Kidney Pal, Josh Lakin, and I sat down together. It was literally a drawing board at the start of COVID and said, okay, who are we going to see and how do we know that they need palliative care? And that process, I mean, we spent like 7 or 8 days like going back over that and being like, okay, no, that didn't work. Like, so I think what we settled on was that each day I would scroll through the list of patients who were COVID positive in the hospital. And then our first priority would to see anybody who was already established on kind of a comfort pathway to make sure that they didn't have any symptoms. And we would see every single one of those patients. And then the folks that were already established that they do not want to be intubated and were already on a high degree of oxygen. And so then we saw, then that was like our tier number 2. So by the end of 2 or 3 months, we had like a pretty well established, these are the patients that we think might have high symptom needs. Those are where we're going to start, make sure. And then kind of the patients who are unstable, who have already well established their treatment goals. And then those that have not had a conversation or were kind of a presumed code status. And then we would get involved in those cases. So I think that's how we ended up thinking that the best way to kind of find patients who could benefit from palliative care was.
And Kelsey, if I remember correctly, there was also a social work-led initiative to do similar screening for patients to ensure that they all had healthcare proxies. Could you speak a little bit to what that process was like and what some of the challenges were?
Yeah, I think we all had our Epic set up in a way that we could easily identify who had healthcare proxies and who didn't. A vast majority did not, and that posed a big challenge. Typically, it's an easy thing to do, but when patients can't sign any paperwork in the room, that posed to be a major obstacle that resulted in us creating a process that was pretty cumbersome and frustrating to all teams involved, I'm sure. But we were able to figure it out.
Thank you. One of the other things I know that was just different with how we were delivering care was family meetings. And I know, Anna, you were involved with a lot of family meetings via electronic devices and platforms like Zoom. Can you talk a little bit about what that was like? How was it to be a medical interpreter trying to facilitate a family meeting via Zoom or another platform?
Well, it was very anxious and also like difficult, with electronic platforms. Sometimes doesn't work, or most of the patients, they just didn't even know how to get Zoom. So so that's how I was calling before the meeting the patients the family members to make sure that they got the app and they can connect. And it was difficult to just arrange. We were texting each other with the providers also to arrange what time will be the family meeting. And also there were so many people at the same time. So it was very challenging to be able to manage all that and everybody talking at the same time and, very anxious because, patients usually, they were brought to the hospital by the family members and sometimes they never saw them again, so they were very anxious because they couldn't see the family members, and when they asked questions, was very, very difficult.
Thank you, Anna. I know we also in our specialty, we rely a lot on seeing the patient. People have spoken to this to be able to manage their delirium and then similarly to be able to help prognosticate. Rochelle, can you speak a little bit about what that experience was like, and especially in the beginning when we were unsure if we were going to be able to go into rooms or even go into the hospital?
Yeah. So the first week I was on, we were really trying hard to preserve PPE, and we had this schedule where some people were home and some people were in the office, and very quickly realized that this was a very stressful time, and that it was really hard to have anyone really at home that was on the core inpatient team. So we quickly brought everyone into the hospital, and then we were pretty careful. We were obviously very careful about PPE, And initially all our patients were in rooms that had glass windows so we could see them. So you didn't have to go in, you could sort of visualize them and get a sense of who they were, you know, what their breathing looked like, whether they were alert, those kinds of things. And then as the surge went on, I remember the first day I got to a door, a wooden door, and I like had this panic and I was like, how can I assess this person and answer the questions that I really need to do without seeing them? And we didn't have later as the surge went on, we had iPads connected to every room, but not at this time. And so a nurse was standing next to me and she like, you look so distressed. And I was like, I need to see this patient. And she's like, well, let's get you ready. And so she gowned me up and helped me get, like, I didn't really know how to properly gown. And it was actually very therapeutic to be able to go in the room and see the patient and assess what I needed to assess. And we were very lucky at the Brigham that we had the PPE to do that. And I really tried hard to only do it when it was absolutely necessary. But there were times that, you know, the question was actually something like, is this person actively dying? And you're looking at an iPad and you're going, I have no idea. Like, I just couldn't do it. I've been doing palliative care for a very long time. And being in the room sometimes for questions like that is really necessary. And so I felt blessed that I really could go in and see patients when I needed to. The other thing that was really funny is that we would bring our iPad in and Kelsey's face would be on it. So we would bring in our team and there was Kelsey on the iPad. So it was kind of a fun thing.
I still do that.
Yeah.
I think it also speaks to, you know, one of the big things that changed, and it was an interesting time to become the consult service director, is all of a sudden, instead of one consult service, we essentially had 3 full-time consult teams caring for patients. And we changed our model to from a purely co-management model where we work alongside primary teams managing patients to 2 teams that were entirely embedded, one within the COVID ICU, so a palliative care team dedicated to those efforts, and then one dedicated to patients that were admitted to the general medical service and patients that were in the ED. And there was a difference in what we were able to offer. The colleagues of ours that were primarily caring for what we would typically be seeing full-time on our consult service were all being asked to do that remotely. And that was another unanticipated source of distress. We rely so much in palliative care on our clinical assessment, on our bedside assessment, because we do tend to tune into some of the nuanced parts of the assessment, like how severe is somebody's delirium or how decisional are they. And that was obviously challenging, not being able to often even visualize patients, but sometimes it's hard for them when they're sick to pick up the phone and have a full conversation or talk about their goals, and they're being asked to do that with somebody that they've never met before. The other thing was end of life was a different experience, and we've heard a little bit about how intense the symptoms were. One of the things that we were, again, very fortunate to be able to do at the Brigham was to have an end of life unit devoted to the care of patients that were COVID positive. We typically have an inpatient palliative care unit that is designed for intensive symptom management and expedited goals of care conversations for patients with oncologic diagnoses, so cancer diagnoses. And we were able to essentially redeploy the staff and the unit that we typically care for patients there solely for the care of patients with COVID. And it was, I think, in the intensity and horror of everything that everyone was observing, it felt like the right thing to do to be able to ensure to the best extent possible that patients received end-of-life care at a quality and consistency that they deserved during this time. It also, I think, one of the things I wasn't anticipating was what happened after someone died of this illness, and how did that go for the family? Kelsey, I know that that was something that you were really involved with. Could you speak a little bit to how you guided families and what some of those different aspects were?
Yeah, there are so many reasons why COVID proved to make complicated bereavement sort of the norm. Just the suddenness and unexpected deaths, and with end of life, we often have conversations about patients' wishes for when they die, funeral services and preferences that they have. And just during this time, the conversation evolved from what the person wanted to just what was even possible and what was legal at the time based on state policies or otherwise. So the loss of just even being able to have a funeral or some sort of memorial was just another loss on top of all the other losses. And it really complicated the grief and bereavement of the families that I spoke with. Funerals are often really helpful in bereavement, just in terms of being able to come together and process the loss and grieve. So families were needing to do that in isolation, like often just alone in their homes, and they spoke to me about how difficult that was.
I remember that became part of the screening assessment. We do that anyway in terms of our loved ones at risk for complicated grief, but adding that extra layer of isolation, and often that they couldn't even be comforted by their own family members for fear of transmission, really made us worried about how people would do and what the downstream ramifications would be in terms of the trauma that everyone was experiencing during this time. The other thing, certainly locally and then that is known nationwide, is that underrepresented minority populations have been disproportionately impacted by this illness. And we saw that in our hospital system as well. And often these patients were patients whose primary language was not English. And that also added a layer of complexity to the care of these patients. And I'm wondering, we'll start with you, Anna. What was it like? This is something that you do in your work every day, is to help facilitate the care of patients who don't speak English as their primary language. What did you see was different, maybe even from the teams that you were interfacing with, the patients, the families?
I mean, we were facilitating, like trying to continue, like the same interpreter, so the way it was like continuation of treatment, I think was very helpful for the families. And, I think like in the meetings, like we were texting, I gave them my number, we were texting each other to be able to talk to the family. I think definitely the conversations, so many different conversations with them. The difficulty for the patients, it was that they couldn't really understand the nurses sometimes, or, they were not understanding the severity of the illness. So we had a lot of different meetings with the family members and trying for them to really understand the severity of what was going on. So it was difficult, but we tried to kind of accommodate with the Zoom meetings and phone calls, conference calls.
It really seems like just when it's a crisis, the blurring of professional and personal boundaries is just there. We all communicate with text messages, things that we may not normally do, but it seemed like a way to facilitate more expedited communication amongst each other so that we can get people the care that they needed. Rochelle, anything to add here?
Yeah, I think it was just so grateful to Anna. The first day we came on, my fellow said to me, every single patient that we have needs an interpreter. And that was very unusual. This is a very different patient population than we normally have. And I think she thought that the residents or the other teams were just being lazy because we didn't really know that the disproportional effect yet. And so we were on the phone with Anna a lot, and it was really we literally could not do our job. Our job was communication, and we literally couldn't do it. We had a couple of pretty difficult situations where we were the first people to give the diagnosis of COVID to patients, and as a consult service, that felt a little bit odd. And so some difficult conversations with our colleagues And one of the things that really helped me through that was just recognizing that this wasn't any one person's intention to not do their job. Like one thing I can say about working at the Brigham is everyone comes in to do an excellent job, and sort of recognizing that those are system issues. When we don't have patients knowing their diagnosis, it's a system issue. And I would say that, you know, the ability to get interpreters and the ability to scale up and make sure that everyone had access to the information they needed was really quite impressive watching it happen. But that's not to say that there weren't mistakes at the beginning, because and you know, one of the things I've learned over time is, like, being at a pretty great institution, it doesn't mean that you never make mistakes. It means that you figure out how to fix them. And so so that made me feel good about the kind of care that we were providing. But at the same time, it was really heartbreaking to see so many families, you know, so many husband and wives or daughters and sons, you know, that were all affected by this disease. So that was just really challenging.
Thank you for sharing. There's certainly a lot of takeaways of things that could be done to improve care for patients moving forward. In the last few minutes, one last thing I wanted to do is highlight one of the palliative care interventions that we tend to do very frequently and informally in the form of a debrief, but that we found was gaining more prominence in a formalized way during this time. So from our perspective, what a debrief typically consists of is, if we have a difficult conversation or have a family meeting, it's an opportunity for the people that were involved to take a step back and reflect on how the meeting went, what went well, what were some of the challenges, strategize together, how things could go better in the future. And oftentimes, because there's a huge emotional overlay with some of the tough conversations that we have, it might also be an opportunity for people to emotionally process what just occurred. I know across the hospital, but our team was heavily involved with these efforts. There was an effort to offer debriefs to clinicians who were on the front lines caring for patients, and also all of us utilized various ways to be able to debrief the experiences that we were having. I know as the consult service director, we had an incredible opportunity. We had transitioned everything to Microsoft Teams, which allowed us to check in via video. Everyone really enjoyed seeing each other's faces and connecting when we had to be physically distanced. And morning and afternoon every day we debriefed. We just asked people to share their day, and people really needed it, and it served different purposes for different people. Kelsey is somebody that was involved on the more hospital-wide system. Could you speak a little bit about how debriefs went and what those processes involved?
Yeah, I'm proud of how the social work kind of department responded. I think it's been in our nature to kind of sense distress and respond to trauma. And I feel like we kind of turned our clinical focus inward to supporting our colleagues. That happened informally and formally. Informal debriefs sort of happened on the spot. I mean, it was sort of a luxury to have time enough to be able to talk. Things were so fast paced and so chaotic that they were really quick at times, but so helpful, I think, for those who were able to do it and just kind of have that cathartic moment of venting and talking about what happened and kind of starting to cognitively process it and externalize some of those emotions and make them concrete. So I think there was huge value in it, knowing that there are short-term and long-term implications of being in that persistent state of trauma for weeks and months.
And I think, again, because this is the expertise of a lot of the people that compose our palliative care teams, it was something that you all strongly advocated for. We all kind of had a sense that people will need debriefs, and sometimes there's a delay in recognition of the importance of that. I know, Anna, you were mentioning that you were just debriefing on a personal level with people that you know well on our team. And yes. Were there also debriefs that were set up for the interpreters?
Yes, we had on Tuesdays, we were getting together with Dr. Abrams and Jessica, and they really helped us to process everything. it was not every Tuesday, but it was definitely like, you know, to express our fears and what we were encountering every day. It definitely helped us to process that and, you know, kind of making sense of, you know, everything and trying to find different ways of helping the providers and the interpreters to just come together in a better way, or, you know, just something that we can provide for the patients and the providers. Definitely, like working as a team, definitely. We were like never before. We were a team. We were just trying to help each other to make a, you know, give a better service, definitely.
Yeah, thank you. That's such a great point. I think that was a common sentiment expressed across the hospital. I know our team collectively felt much closer to each other and very quickly developed relationships across the hospital with people that we may not have worked with frequently pre-COVID. This is a really great discussion. I'm hoping that we can conclude with just one takeaway. What is something that we're about 2 months out from our surge at our particular hospital? I'm wondering if we could share one reflection or one thing that we still are thinking about frequently from this experience. And I will start with Kelsey.
Personal and professional takeaway, I think just the importance of proactively reaching out to people when they're on their mind, when you're worried about them or not, just before anything happens, just reach out. I had a patient who didn't make it to the hospital yet, but I called him maybe a few weeks before and had my last conversation with him. And he got sick a few weeks later, so.
Kate, what about you?
Oh, what's my takeaway? I think I throughout this whole thing have just been humbled and impressed by the strength of people in the community. I think, you know, no matter who I called and said this is what's happening, they were so grateful and thankful, and I just was always impressed by how strong people were and how their ability to kind of take crisis and take it in stride and work together and say, okay, what do we do now? And it's just like totally humbling for me from both the in-person, like both a team standpoint and from an outside community standpoint. So that's what I've been thinking about.
Thank you. Anna?
I take away that, you know, I felt like much closer to everyone, all the providers than ever, like what I said before. And I'm taking that because, I mean, I realized like, you know, everyone gave like beyond expected, you know, to come together and help each other. So I'm taking that. I just feel part of the team, like, you know, really close to everyone because they do a great service and they are trying really hard to do their best, that's for sure.
I know that everyone is equally grateful for you and your team as well. Rochelle, what else would you add?
It's actually the same. It's just being so grateful to work on this team. You know, from Anna would text us back whenever, you know, immediately and let us know that she could interpret for us. And Kelsey, I knew, would follow up, or Kate, you know, we could struggle with, was this the right thing to do or say? And scrolling through the lists. And, you know, I felt as one of the more senior clinicians, palliative care clinicians on the ground, it felt like a lot of responsibility. And then at the same time, to feel like you had such a strong team, I felt like we provided really good care at a really, really hard time. So just really grateful and blessed really to have this group.
Thank you all for sharing all of these reflections, and thank you all for listening. As a closing reminder, attendees can gain continuing education credits for participating in today's session. To do so, please click on the link in the description below this video window to complete the evaluation and obtain the credits. The information will also be distributed through a separate email to today's participants, along with links to a recorded version of today's discussion and credit information. The email will also include additional HMS COVID-19 resources. please distribute to colleagues that you feel would benefit from this information. Thank you again for joining us in today's discussion.
Thank you.
Thank you.
Thank you. Thank you.